Gynae, National Postgraduate Medical College of Nigeria, members of the faculty board, facilitators, trainers, respected colleagues, researchers, guests, good evening. I'm so glad to welcome all of us to this seminar on research proposal writing. The emphasis today is on randomized controlled trials, cohort studies, case control studies, and qualitative and mixed method research designs. You know, you see that in today's rapidly evolving research environment, the ability to develop a clear, rigorous, and fundable research proposal is not an option. Whether we're conducting clinical trials, observational studies, or exploring complex social and health phenomena, whether we're using qualitative and mixed methods, the strength of our proposal begins with the quality, the strength of our research begins with the quality of our proposal. Hence, this seminar. The seminar has been carefully designed to bridge the gap between the research ideas and well-structured proposals by highlighting methodological considerations, study design selection, ethical issues, and practical strategies for developing competitive and scientifically sound proposals. We're privileged to have seasoned facilitators who will share their expertise, practical insights, etc. We encourage all the participants, both the trainers and the trainees, to engage actively, ask questions, and take a full advantage of this learning opportunity. We are going to have 3 speakers. The 3 speakers are, the first speaker is going to be Professor Valentine Ugu. He's going to talk about randomized controlled trials. He is from the University of Nigeria, Nsukka. The second topic will be on cohort studies and case control studies. That will be by our own Professor Swende. Professor Swende is from Benue State University Teaching Hospital. And then we will now have our own Professor Kike Lomo Adeshino tell us about qualitative studies and mixed methods. Professor Adeshino is from the University of Ilorin. I want to believe that we are going to have a very fulfilling time. Each speaker has between 15 to 20 minutes to give us what he has. And then questions will be taken at the end. All questions will be pulled together. Either you raise your hand when the time for questions reach, or you put it in the chat box and we'll take it from there. And so may I humbly invite Professor Valentine Ugu to please take us on proposal writing for randomized controlled trials. I'm sure it's going to be a wonderful outing. Welcome, Professor Ugu.
Yeah, thank you, the moderator, my chief, and the CMD, Dr. Emile Zeribe. Good evening, sir, the EBU chairman. Good evening, the secretary. I can see the secretary, I can see the assistant secretary, Professor Wendy, and good evening, my senior colleagues, and of course the residents. I've been asked to give an overview of proposal writing for randomized controlled trials. And I will ask to do this just within 15 to 20 minutes. So let me do that as quickly as possible. I have no conflict of interest to declare. Now I start right away. Why is randomized control trial proposal? Why must it be excellent? That's the question that we will start. Why is RCT proposal? Why must you get it right? Why is it why must it be excellent? It must be so because it is the gold standard for evaluating interventions. So of all the proposals that you write, you have to have it at the back of your mind that the gold standard for evaluating any form of intervention is randomized control trial. And when you have a systematic review and the meta-analysis of randomized control trial, we are now talking about the highest level of evidence. So it's something you have to take very seriously, especially at this early stage of your career, because a poorly written RCT proposal will result in rejection. It's likely going to be rejected. And if you submit a poorly written proposal, there may be some ethical delays and to result in a weak science. So we must be very, very careful when we are approaching RCT designs. Now, if you're writing a proposal, RCT proposal, it's always important from the beginning to consult the spirit protocol. I'm sure by the end of this lecture, I expect all trainees to download the spirit protocol and look at it, because it will guide you anytime you are writing an RCT. We just have limited time. So we're not going to go into some of these details. Make sure that all the contents of that protocol are adhered to strictly. And when you finish writing the proposal, at the time you are writing a report, as going now, when you have finished your protocol and you have collected your data, you want to write up the study, make sure you have the consult guideline, which will ensure that everything that is expected of an RCT is included. Is a reporting guideline that must be followed. So you follow the spirit during protocol, and then you follow the consult reporting guideline when you have finished the study and you want to report your findings. Also very important is the ICMJE and GCE principles. The ICMJE is the International Committee for Medical Journal Editors, and then the GCP is the Good Clinical Practice Principles. These principles must be strictly adhered to at the time you are writing your proposals. So make sure you produce something sound that should not be rejected. Still, as part of preamble, why must you follow the ICMJE protocol or guideline? If you follow it, it will ensure that when you finish your study, that your study will be publishable, because it will guide you to make your proposal to be transparent. It will ensure that your proposal gets ethical approval, and it will also ensure that there is standardized reporting. So the ICMJE principle will ensure that a proposal meets these qualities. And of course, the good clinical practice principle will ensure that your proposal is ethically and scientifically safe, to ensure that it will ensure participant safety, to also ensure that you conduct your study ethically, and that at the end of the day, your study will have scientific validity. Now, let's come to the core components of randomized controlled trials. Now, if you're writing your proposal, you should ensure that at least these are the minimum requirements that must be in your proposal. I'm sure Professor Ledet took us some time, I think yesterday, on the components of the proposal. I mean, what and what are expected to be in the proposal. But for RCT, these ones I've listed to now in this slide must be there. They must be there. So the title, the background, justification, research question, objectives must be there. Because of time, we need to move faster. Now, let's come to the title. Very, very important. And I want the students to listen up. Now, I have to caption it that the first impression matters. So if I look at your RCT, it will tell me the quality you have in terms of it will define immediately the level of knowledge you have. If you get your title very well, it will be assuring. Somebody who is looking at your proposal will be happy if you get the title appropriately in the beginning. So for the RCT, we usually encourage all over the world that the PICO standard should be adopted. I'm sure we know what it is, but for the purpose of revision, ensure that your title has population, it has a clear intervention, it has a control, and that the outcome is clear. And then, very important, that you have a study design. Initially, they said PICO, but currently they are adding S to it, which means study design. So if you finish your RCT, if you are doing an RCT, it's expected that the term randomized control trial, which is the design, should be added there. Don't leave it at PICO alone. Make sure you also include the study design, which is the S. So let me give you an example of a study I've done in the past. Now, example is a randomized control trial of oral misoprostol versus oxytocin for preventing postpartum hemorrhage in low-risk women at UNTH. This is just as an example. If you look at it, the population here is low-risk women at UNTH Enugu. That is the target population. What is the intervention here? The intervention is oral misoprostol. What is the comparator, or what we commonly call the control? The control here is oxytocin. And what is the outcome measure of interest here? Is preventing postpartum hemorrhage. And what is the study design? Is randomized control trial. So somebody who's looking at this title, perfect. All the 5 components of a good study title for RCT, they're all there. In fact, we encourage even cohort studies to have this. But most importantly, the RCTs must have these 5 components. So at any point in time, you are writing your title for randomized control trial, make sure that these characteristics are clear in your title for anybody to see. Now, the background and justification. Now, when you are writing your background or introduction, make sure that you have a brief global context of what is known about what you are studying. After the global context, look at the regional, national, or even global gap. Because after you have talked about what is known about that is about the study you want to embark on, you have to look for knowledge gaps, because every study is expected to fill a particular knowledge gap. So if you have done a good literature search, you should be able to identify gaps and know where you have the regional, national gap that you want to fill. And sometimes a global gap if you have done a good literature search. Now you ask yourself, why an RCT is necessary for this study? If you think that RCT is necessary, there is a terminology we usually use, equipoise. Equipoise means that because of ethical reasons, ensure that at any point in time that there is no already known superior treatment at the time of trial. Because if there is a superior treatment, you can ethically randomize somebody to an inferior treatment group. So you should make sure that at the time you are conducting this study, or at the time of your proposal, that there is equipoise. There is no particular treatment that is superior to the other. Otherwise, if, for instance, we already know that magnesium sulfate is the gold standard for managing women with for preventing fits, preventing eclampsia. So if you want to do an RCT comparing magnesium sulfate with another trial, you have to be very, very careful. You can't give a patient an intervention that is less than magnesium sulfate. Otherwise, it will not pass ethical approval. Now, you have to end this your introduction of background with a clear justification of the study. If you finish writing a proposal and there is no clear justification in terms of the knowledge gap that this your study wants to fill, then you have not done a good background. You have not done a good justification for that study. Now, it's always important that you cite recent literature. High quality literature should be a priority. There are several literatures. So when you are doing your literature search for RCTs, it's good that you concentrate on high quality literature and preferably those within the last 10 years. Now, another core component of RCT that residents must know very early in their training before they embark on the study is the research question, the aim of the study, and the objectives. Very, very important. Because oftentimes we have, some of us are usually very, very angry with residents or even junior academics who just write these things any way they want to, because these things follow international standards. There is a pattern in which research question is written. No hypothesis has a way it is written. Like it must follow the PICO standard, the PICO format. If you want to write the research question, you must make sure that all the population is there, that the intervention is there, the control is there, and the outcome must be defined in that research question. You don't just throw away research question anyhow. Because of time, I may not go into it. The same way when you want to write a null hypothesis, there are standard ways of writing it. And before you drop your null hypothesis, when you finish writing, ask yourself, has it followed the PICO format? Has it followed the PICO standard? If it has not followed it, you have to adjust to make sure that those components are there. Otherwise, you have written a poor research question, no hypothesis, because we score this thing, especially when you are asking for grant. If you are writing for a grant, you will know that the way you write these things are very, very important because they are scored. And the objective is a broad statement of intent. Always know that your objective, then I'm talking of the aim now, not objective. Always know that your objective is derived from the title. So you write the objective from the title. Sometimes you see people having a different title and they now come to the aim of the study and start writing something else. So the aim of the study is derived from the title. Then we come to the objectives, very, very important. All your objectives must be smart. Oftentimes we have seen people throwing up objectives carelessly without making sure that they are smart. It must be simple, measurable, attainable, realistic, and must be time-bound. If any objective you write, you make sure that all these components are there. Otherwise, you'll be poorly. For those people that have reviewed their dissertations, I keep quarreling with them until I don't approve their proposal until they have made all the objectives smart the way it should be. Now, there should be, make sure that you select your primary objective. Your primary objective should be one, most times, and at most two. And it is upon your primary objective that your sample size will be calculated. It's also from your primary objective, they are going to derive your null hypothesis. A few days ago, I had the privilege of examining some PhD candidates from a Nigerian university. And I noticed that they were just throwing objectives. The null hypothesis was calculated, was talking about a secondary objective, and the sample size was derived from a secondary objective. No, your primary objective is what you use to drive your null hypothesis, okay? And it is also based on your primary objective, they are going to calculate your sample size. Because if you finish your study, you should be able to address your primary objective. Your study may not even be powered to address some of your secondary objectives, and that will end up being some limitations that may be acceptable for your study. but not for the primary objective. You can't finish a study and your study is not powered enough to answer your primary objective. So your primary objective should just be one at most two. If you have two primary objectives, then you must have to calculate your sample size for the two and use the larger one. Then secondary objectives, even though it should be many, but it should be limited. Maybe 5, 6, at most 7, 4, 5, 6. At PhD level or at fellowship level, one would expect you to have at least 6. Anything less than 4, not acceptable. Don't make it more than 6, 7. So it should be many, but it should also be limited. Study design and setting. Now, there are different study designs that you may decide to choose. It could be parallel RCT. Parallel RCT could also be a superiority RCT or a non-inferiority RCT. So when you are designing a study, you need to know what you are doing. Are you dealing with a superiority or inferiority? Okay, the non-inferiority is what we also sometimes call the equivalence RCT. Each one is very, very important. I encourage the residents to read them up. Because of time, we won't be able to define each of them, but the type of design you are doing will determine the sample size formula that you use. It will also determine the calculation you are going to do. So you have to be very careful. And also your study title and objective will also determine whether it should be a superiority RCT or a non-inferiority RCT. Most times you see candidates coming for exam, they don't know the study design they are backing upon. All these things must be sorted out at the level of proposal so that it should be clear before you embark on that study. So the study setting, you must define it clearly in your proposal. And in your study population, make sure you have your inclusion and exclusion criteria. Your recruitment strategy must be clearly stated. And what is expected internationally for every proposal or every research is reproducibility. When you do your proposal or even when you finish your work, ask yourself whether this study can be reproduced by another person in another setting. So it must be clear, and that's why it is always good in your proposal to use the spirit guideline. And when you also report it, use the consult guideline, okay, when you have finished the work. Now let's go to the randomization proper. Now the randomization could be computer-generated sequence, or you can even be the simple lucky dip method. But we usually encourage people to use the computer-generated sequence. It could also be, and if possible, at any point in time, it's better to do the blocked stratified randomization. Because of time, we'll not be able to explain some of these details. But if it is possible, that should be the highest level of your randomization when you do it in a blocked and stratified form. Allocation sequence, seed, opaque envelopes, center randomization, all these things must be taken care of. And when you are then blinded, depending on the nature of your study, you will know whether it will be single, double, open, or open label. Now, some people go and each one is unique depending on the type of study you are doing. If your study should be single, don't try to impress anybody by making it double, because if you make it double, the questions that will ask you, you will then realize that it shouldn't have been double. So, but if you can make it double, better, because the double blind will give you, will have less risk of bias. Now, make sure randomization is good, because if it is not good, it's going to render randomized control trial invalid. Now, very important, sample size calculation. I said it before. Make sure that you must calculate sample size. Don't run away from it. Ask your senior colleagues to guide you, because this is a very important aspect. Otherwise, you'll be dealing with sampling error. So if you get the sample size wrong, then your study is invalid. And ensure that you are calculating your sample size based on the primary outcome. Like I said before, don't go and start calculating your sample size based on your secondary outcome measures from your secondary objectives. Always use your primary objective to calculate your sample size. so that this your study will be well powered enough to answer the primary objective. Sometimes it may not be powered sufficiently to answer the secondary objective. That could be forgiven and used as part of your study limitations. But if your study is not powered enough to answer your primary outcome measure, based on the fact that you went and calculated the sample size using a secondary outcome, then it renders your RCT invalid and reduces both the internal and external validity of your study. Of course, the power should be at least 80. You do 80, 90, but anything short of 80 is not acceptable, and set your significance at 5%. So your outcome measures must be clearly stated. Have your primary outcome, then your secondary outcome. The measurement too, the instrument they are using to calculate your data should be clearly stated, and the timing of collection of that data must be clearly stated. What of ethics and data collection and the feasibility? Ethics very, very important. So make sure you seek for ethical approval. It's institutional review board of your hospital. Write it. It must be clear when you are writing. In fact, I think both colleges should request that you even put a copy of that ethical approval. But at the time of publication, one would expect you to put the ethical approval number, including the date of that approval. It's compulsory for most high journals that you must include the ethical approval number and date. You must get informed consent, very important, and if possible, get written informed consent. There must be statement of monitoring safety. And very importantly, too, you must report adverse events. In fact, if you do an RCT that requires some measurement of adverse events and you omit it, when they are doing, if your study is selected for systematic review and meta-analysis, they will reach you. They will reach you and ask you to supply them with the data. So once you are doing a study, consider whether there are some adverse events that could be associated with that your study, and make sure that you cover for them at the time of proposal, and also provide data during reporting. Data analysis, usually we prefer intention to treat more than per protocol. So for RCT, intention to treat principle should be adopted most of the times, except where not applicable. And you must make sure that your statistic must match the outcome. So the statistical measure you use must be related to your outcome measures of interest. Also ensure that this your study is feasible by noting the timeline. For both colleges, they're expected to put timelines on when you want to do a particular thing, to be sure that this your study is feasible, and ensure you have the resources. And by the time you finish, you should be able to anticipate challenges and possible limitations and how you are going to mitigate around them. Finally, this is the last here now, to make it as short as possible, you referencing. Now, you can't write an RCT proposal without adequate referencing. I've told you, use high quality literatures and limit them to as less than 10 years, except where very, very important, except if there are landmark trials, landmark studies that are more than 10 years could be included. Otherwise, limit your literature, your searches to 10 years. And I've said before, where you cite the spirit guideline, you make sure it's appropriately cited in your references, or the consult, which you are going to use when you are doing the reporting, when you have finished the study. Now, what are the take-home points for this short overview of proposal writing for randomized control trial? RC proposals must be methodologically airtight. It must be airtight. There should be no compromise. Everything must be there. Ensure you use the spirit protocol and make sure that all the key components of the spirit protocols are included. And for the method section to be appropriate, always think ethics. Make sure you get ethical approval, and make sure that everything there, informed consent, that they are all there. Also, think about feasibility of what you are doing. Make sure this study is feasible, because if you write a proposal, it will be sent out to your seniors for review of the proposal. And if you think it is not feasible, we're going to reject your proposal. And finally, make sure it is reproducible. Is this your study? Is this your RCT reproducible? So you must be detailed enough and be clear enough that anybody who wants to reproduce your study elsewhere in another setting will be able to do it exactly the same way you have done it. Thank you all for listening. And
And
I'm ready to
thank
some of
you.
your questions and discussions. Thank you, the moderator. Thank you.
All right, that was a wonderful, very clear guide to writing a proposal for a randomized controlled trial. I can see people are already giving the electronic round of applause. Can we have more of it for our own Professor Valentine Emmanuel O. Ugu? He has told us a lot. He has emphasized that we should use the spirit protocol. I mean, he said it repeatedly about ethics, about reproducibility, about good clinical practice principles, and about ensuring that we use the PICOS, how we do our null and alternate hypothesis. He's been very detailed. Thank you once more, Professor Ugu. Please kindly put your questions in the chat box. Some people are already doing that. While we receive the next speaker. The next speaker is none other than Professor Teruman Swender. He is a very principal and key officer of our college. I mean, and I know there's more coming up for him. And he's going to take us on cohort studies and case control studies. Professor Swende, good evening, sir. Is Professor Swende around? Prof. Swende. Are you muted?
I think the admin needs to make him a co-host.
My chairman, sir, good evening.
Good evening, Madam Moderator. Thank you very much.
Thank you, sir.
They should join. Well, maybe his network is. Okay, sorry, I've got him on the line. Let me just ask what's happening. Hello, TZ, they're waiting for you now. Are you not joining? Rejoin. Okay. All right, I'll tell them you're trying to rejoin. Okay.
Maybe they can start with question or even go.
Okay, he's having network issues. So his network logged him out. So while he's trying to rejoin, I think we can move to the next speaker.
Okay. The next speaker will be Professor Kike Lomo Additional. She will be taking us on qualitative studies and mixed methods. Professor Adeshino, are you ready? Thank you.
Yes, please. Trying to share.
Thank you very much.
Don't know if you can see my slide.
Not yet.
Not yet.
Yes.
Okay.
Yeah, we can see it now.
Okay. So let me reduce all these icons. Just a minute to put it on slideshow. So good evening once again, our moderator, our chairman, other members of our faculty board, senior colleagues and colleagues. So today I've been given a wonderful task of discussing qualitative and mixed methods. I think I have 15 minutes to do that, right?
Yes, you
Madam
have 15
Moderator?
to 20 minutes to do that, please.
Oh, okay. So the wonderful presentation by Professor Ugu is well applauded because it gives us the various sections when we are writing proposals and the importance of the design that was discussed. Also, importantly, we notice that there are some in our college that some types of proposals may not be welcomed because of design. And that's why I've been given this task to discuss qualitative and mixed methods as options. Generally, for now, we know that this may not be a form of designs accepted because we're trying to make sure that we do studies that are scientific, reproducible, with well-designed structure and what we can actually, count as academic. But the truth is that qualitative and mixed methods of study designs are very important. And it's important for us to understand them. And on that note, this evening we'll be looking at what qualitative studies are and what mixed methods are. We're going to be looking at doing sampling, data collection, and even reporting standards for qualitative and mixed methods. And finally, I will just be making some advocacy, some suggestions, and talking about concerns when it comes to reviewing and looking at the risks associated with such study designs. So by way of definition, we see that qualitative studies are studies done usually when we need to go in depth. Qualitative, if you look at the word qualitative, means you're looking at quality. So most times you do not have numbers. So there are non-numerical data that we collect and analyze. And these are generated from discussions, from observations, from interviews. So, and they are important because they help us to explore how and why patients or providers have such experiences and how to, to look into them, even when we look at other sides of implementation, like implementation science. It's also important to know that the other type of studies, so because when you write out studies, they might either be qualitative or quantitative when we look at the kind of data generated. So when we have data that are numerical as well as non-numerical being done in a particular study, we talk of mixed methods research. And it's very interesting because there are studies, qualitative studies especially, are well grounded in social sciences, and they are very important in our own type of in our own studies too, because they tell us more information. Most times when we do other study designs, when we look at RCTs or surveys, we miss lived experiences. So qualitative studies help us to look into that, to explore, to understand the phenomena. But when we look at mixed methods, we are actually now saying that we are doing both quantitative and qualitative so that we can use numbers and we can use narratives to get more, explanation. And that's why when we design qualitative studies, we hear things like, are they exploratory or explanatory? So exploring is that you are going deeper. Explanatory means that you are doing a research in which you are trying to explain most times a behavior or a reason. I give examples here that sometimes we want to know what patients believe about garment donation. you'll be surprised why people choose it, why people don't. And when we now look at that in that way, we'll be able to get messages, data that will help us in managing such patients and that. Whereas when we look at mixed methods, we now look at data that you can measure. Maybe you want to look at obese patient. Now you want to even know what pattern of obesity you have. So that would be like a quantitative thing. And then you describe what their beliefs are, why they comply with results or with weight management. So in summary, we are looking at both quantity and quality, if I can just use that to explain when we talk of mixed methods. And when we talk of qualitative, we are just limiting ourselves to what to explore or explain. So when do we consider such studies as, for example, qualitative research? We consider qualitative researches when we look at attitudes, behavior, perception, when we cannot explain just using data, just using numbers. Let me use that word. So that we need non-numerical explanations, narration, interviews to get our answers. And they also help us to study relationships. So next time we're looking at designing knowledge attitude practice studies, it's important that we look into the qualitative and the quantitative aspects so that we can we can get more information. The same goes, into the fact that there are sometimes because of problem of ethics or methods, you cannot actually collect, number, but you need explanation. So in the too young or the vulnerable, you may have to consider qualitative research method. So when you're planning qualitative studies, what do? Same thing you do when we do research. You have objectives, you have problems, and then we know we have subjects, we have participants. And then that's important. We identify the key stakeholders. For example, you're doing a study on women, and that you're doing a study on maternal mortality, for example, maybe following blood loss. Definitely, your study review will be among women who are delivering or are pregnant or about to deliver or had experiences in PPH. So that's the way to look at the key stakeholders. And you need to define your data to address the research question. That is very important. And one thing that scares some persons from, writing out such studies, because they think, well, would people think this is feasible? Would it be analyzable? But the truth is that they are analyzable, and we look at how data that are non-numerical are analyzed and reported as we go on. And of course, we should not forget that the research questions, research objectives must be SMART: specific, measurable, relevant, achievable, and time-bound. So I just use this to depict what we do, when we try to develop a proposal or a study using qualitative method and even mixed method. So this is just a template. We should always remember, because that's one thing we take note of sometimes, that people, go the other way. They start from up, go down. The real thing is that we should have a background and a sound research problem. That's when you'll be able, to plan and have a pilot analysis so that you can really construct relevant questions and not just, go the other way, starting, with your objectives, and then you go the other way. So it's good to always follow this construct when we're looking at designing our study, to know the background, to know the problem, to have a preliminary, idea of what we want to do, and then construct possible meaningful research questions, and then hypothesis and the aims and the objectives. So when we design qualitative and quantitative studies where we have them mixed together, as that's mixed methods, there are many options of design and sampling. So when you talk about design of option, you could look at, maybe you want to study a phenomenon. So that means that your design is a phenomenal design. or there's a theory that's already known and you want to further support that theory. And that's why it's a very common design among social scientists. Or there's a case. We observe, we observe a pattern. We observe, for example, a pattern of death in a group of persons. For example, maybe following Cooper sepsis in a group of persons. So you can take a case study or people that survive, for example. So you can look at maybe some group of near misses and then study together and say, okay, we can do an evolution in this. So it means that you are basing your design on whether it's a phenomenon or a theory or a case that you are trying to explain. And so that also goes for mixed methods. And for mixed methods, it could be convergent or sequential. So I'll give more explanation on that with a diagram. The idea with a convergent means that you're starting the study together, both the qualitative and quantitative aspects, and then you carry on in your design and you merge them as you go on. Whereas if in an exploratory, sequential, or exploratory, your design is qualitative at the start and you bring in the quantitative aspect as you go on. So that way you're able to do that. And that way you're able to achieve that aim. And should also mention that we still have other components. For example, sampling, when you talk about qualitative and mixed methods studies. So for most times qualitative, we always say that, well, since you are doing most times interview, focus group discussions, probably you could have 15, 20 participants. And then some will say maybe between 8 and 12, depending on what you want. So most times there's some flexibility. But then your sample size may be determined by either saturation or being pragmatic, that being practical about what you're doing. Or saturation means that you've taken your participants a particular number and you are generating the same answer as you add on to them. So it means that you do not need more persons to
Professor Additional, we can't hear you again. Your audio is gone. Professor Additional, you might need to log out and log in again. Your audio is gone.
It seems we have lost Prof.
Let's just give her a minute to log in again.
Yes, we have to.
Is there Professor Sunday? Professor Sunday, are you on with us? Professor Sunday.
Media support says she's offline. Professor.
I know, I'm asking about Sunday. I think Additional is trying to log in back again. So let's just give her a minute.
We don't have a choice.
I think Madam Moderator,
Yes.
let's just start taking some questions from Professor Ogu from the first
I think
lecture
that's
while
what
we're
we
waiting
should
for
do.
the others to join us.
Okay.
I
So
think there's some questions in the chat box.
yes, there are questions in the chat
So
box.
for Professor Ogu, so while we're waiting for additional and Sunday, I think they're
I
having
even think
some
he's already
network issues.
attempting to answer them. Okay. Okay, the first question is oh, thank yous.
Yeah, the first one asked on thank you, the moderator, and thank you, the chairman. I think I'm in the chat box now. The first question is the first candidate, Sadaut. Okay, she asked if it is possible to conduct an RCT.
Sorry, please hold on. Kika is my chairman, sir. Sorry, please, Professor Ugu, please. My chairman.
All right.
Yes.
My chairman.
Yes.
Prof Adeshina is trying to log in and she's not able to. I don't know who can help her.
I mean, logging how? I don't understand. She has to check her
She's
network.
trying to come back on.
Oh, okay. She has to be admitted.
Yes.
Media support, please. Professor Buka.
Yes, Dr. Iwara will handle that.
Can they admit her, please?
Yes,
She's
Dr.
in the
Iwara.
waiting room.
Yes. The media support, please.
Yes, sir. The waiting room has been disabled, so anybody can log in freely. We just have 293 participants, so she can log in. Maybe she has network glitches. Thank you.
Oh, that's great. Okay, thank you.
Okay, Professor Ogu, please answer the question.
Okay, sir. So, sir, the first question, the candidate wanted to know whether it is possible to conduct an RCT without blinding the participants, but rather the examiner and the data analyst, and still consider it a double blinding. So I have answered that. I don't think it is possible to do that because when you talk about double blinding, it means you have blinded the participant or the outcome assessor, or even the statistician. So, or the triple blinded. So if the participants are not blinded, you cannot call it a double blinding because you have blinded the outcome assessor and the data analyst. No. The design is still an RCT, but you shouldn't use the term double blinding. Like I've stated there, you should call it what it is. You should just state clearly there that the analysts and the assessor are blinded in this randomized control trial. It is clear. Don't try to be ambiguous. You don't. Sometimes I notice that candidates try to impress the assessors or the examiners. No, be clear. If it is not double blind, it's not double blind. For you to say it's double blind, it means the participants are blinded and the outcome assessors are blinded. So you can't leave the participants cannot be, they can't know the trial they are receiving, and yet to say it is double blinded. So it is not double blinded. No, it can be called double blinded RCT. Then the next question is, can a software be used to calculate sample size like the G-Power for National Postgraduate Medical College? And he said, well, my response to that is that I'm not too sure about that. Maybe Chairman will tell us. But if I have a proposal where a candidate used G-Power at proposal level, I will return it and insist that the candidate uses the appropriate sample size formula. The whole thing is at this formative phase of your training, you should try to know the right thing. When you become a fellow, a senior academics, you can start to be using G-Power. You should know the rudiments and know those different sample size calculation formulae. You should know the different ones for difference in mean, ones in difference in proportion. You should be conversant with them and be courageous enough to use one, and we want to see how you calculated the sample size. For me, I don't joke with the sample size calculation. In fact, it's an aspect that I go, and I always insist that you use the appropriate formula, and the effect size and everything are well applied. Otherwise, you continue correcting that until I'm satisfied. So maybe the chairman will help us, whether it's allowed at National Postgraduate Medical College for people to use G-Power. I'm not sure there is a clear thing about that. The chairman may help throw more light on that. But if I receive such proposal, I will not allow it to go, except if the chairman says otherwise today. Now, he's also asked,
Sorry,
what is
Professor
the
Ogu, can
sample
you
size?
just pause a minute? Let Professor Additional just complete our lecture quickly.
She's back.
Okay,
He's
sir.
back.
Thank you, sir.
Thank you. So you take it from where you stopped and she finishes.
Professor Adeshina, welcome back. Please go on. Are you muted?
Hello, can you hear me now, please?
Right, loud and clear.
I'm very sorry. I didn't know I was talking to Seth all the while until I saw the cutoff.
Okay.
So I think I was talking about the sample size that usually and I apologize, sorry for what happened. I was talking about the sample size that most times we look at maximum of 50 to 20 participants when we look at qualitative research, but that the rationale for getting a sample size may also look at the methodology of having saturation or being practical about what number to bring on board. Saturation just means that if you start your qualitative study, your interviews, your discussion, and you keep getting the same, pattern of answers from the same, from the group of persons, you may just say that you have actually reached a saturation and you do not need to add more. And the usual the practical approach means you look at what you think from your assessment and design will be required, the number you be required to do the study. So these sampling strategies most times for qualitative research could be, most time purposive sampling, where you look at the selected and the selected participant question, or you do a snowballing where your recruited participants come in, more persons, earlier recruited persons or networks, or you even just base it on a theoretical consideration. And it is also important that you may do a variation sampling. And when you do that, you could you could select people with diverse characteristics. Hello, I hope I'm still there. You can hear me.
Yes, we are hearing you.
Hello.
We are hearing you.
Thank you very much. Need to be reassured.
We can hear you,
So,
Professor Additional.
Thank you. Thank you very much. So that's this diagram just shows us the various ways of doing mixed method research design. It could be convergent, as I mentioned earlier, or explanatory sequential, or exploratory sequential. Either way, you are starting with something exploratory or quantitative, and then you add on the other qualitative aspects. So that's the idea. Or convergent means that you go right away with a quantitative design for collection analysis and then you merge. So that may be a way of looking at designs of major mixed method studies. So as a way of collecting the data and also looking at analysis. The good thing about this study design is that it allows us for flexibility and to bring on board what works for the different, the type of research work you want to do. And so we can just look, if you take a look, for example, at the various components in this diagram, you will see
Has it happened again? Professor Adeshina. Oh no.
She's still with us,
Oh, she is. Praise God.
but I think I don't know. I can still see her online, but our microphone is not. So I guess it's a network issue. She's offline again. Network is really messing up today.
Yes, it is.
I think Professor Ugu can quickly go back to his questions.
Yes.
Thank you, Chairman and the moderator. I think I've addressed the first one by saying emphatically that if the participants are not blinded, you cannot call it a double-blind RCT. Either just say it is single blind or say it is assessor analyst blinded RCT. Don't call it double-blind if the participants are not blinded. It's only double-blind when the participants and the outcome assessors are blinded. Now, like I was the G power calculation for sample size. Chairman, I don't know what's your view about this, sir. But my view is that the candidate should use the appropriate sample size formula.
Yes,
so that we see clear. Yes, sir.
Yes, I agree totally with you. It's not for as far as college is concerned now, they're supposed to bid manually. They can't use G
G power.
G power. So I totally agree with you. The college is actually going to the college at the last Senate approved some policies on AI, use of AI technology in the college. So very soon they're going to disseminate to all the residents and trainers. So I totally agree with your stand.
Okay, thank you, Chairman. Thank you, sir. Now the candidate also asked about 3-arm RCT. The 3-arm RCT, there is no different sample size formula calculation for 3-arm or 2 arms. Whether it is 3 arms or 2 arms, they are the same. The formula is the same. But what is important is that when you finish calculating, the minimum sample size N that you obtain is for each arm. So if you get 50 as your N, it means for the 3 arms, you will have minimum of 50 for each arm, making it 150. And that the sample size formula that you're going to use is going to be based on your primary outcome measure. So there's no different sample size formula for a 3-arm RCT. It's the same. Either you are talking about difference in mean or you are talking about difference in proportion, as the case may be, it still remains the same. Okay, top notch. Once again, I'm coming. Can we get the slides? I will send the slide to the moderator when we finish, so that you can also see. Now, yes, a candidate asked, can you give further clarification on primary and outcome, primary and secondary outcome, primary and secondary objectives, possibly with examples for clarity, Prof. Okay, good. Now, let's go to the study I posted, the example I gave, a randomized control trial on the oral misoprostol versus oxytocin for preventing primary postpartum hemorrhage in low-risk women in UNTH Enugu. Now, if that is the title of the study, you know your primary objective here is the incidence of postpartum hemorrhage in women who receive oral misoprostol compared to women who are going to receive what? Oxytocin as your control. So what you are looking for here is the incidence of what? Postpartum hemorrhage. Some people will also be talking about the mean blood loss between the two groups. That's where the problem is. because what you are looking for is incidence of postpartum hemorrhage. You are not looking for the mean blood loss. That's where candidates get some level of confusion here. If you look at that RCT that I posted there, it's looking at, it said a randomized control trial of oral misoprostol versus oxytocin for preventing primary postpartum hemorrhage in low-risk women at UNTH Enugu. Now, our primary outcome measure is what? Primary postpartum hemorrhage. And we know how we define primary postpartum hemorrhage. If it is for normal delivery, we use 500 mils. If it's for cesarean section, we use more than 1,000 mils. Okay? And also, if there's any change in hemostatic or hemodynamic status of the woman, irrespective of the blood loss. So when you have defined that, your primary outcome measure here is the incidence of primary postpartum hemorrhage. That is your primary outcome measure. So if you're calculating sample size for this now, you'll be looking at, and your control is oxytocin, you'll be looking at previous studies. For instance, a previous study using oxytocin to prevent primary postpartum hemorrhage. What is the incidence of primary postpartum hemorrhage? In a previous study where oxytocin was used, because oxytocin is now your control. But your intervention here is oral misoprostol. Since oxytocin is your control here, you have to look for incidence of primary postpartum hemorrhage in women that used oxytocin to prevent postpartum hemorrhage. It's upon that you are going to set your effect size and look at what difference you are going to have. Are you saying that it's going to set a 30% difference of that oral misoprostol is going to reduce it by 30%, or it's going to reduce it by the incidence by 40%, as the case may be? So you have to set your effect size and calculate it accordingly. Now, in this same study, you could have some other secondary objectives. For instance, you're going to look at women who had misoprostol and women who had oxytocin. What were the adverse events that they had in terms of maternal adverse events? We know that misoprostol often causes some, it causes rigor, it could cause shivering, it could cause this and that and that. That is an adverse maternal event. In the baby, we're also looking at the APGAR score, incidence of birth asphyxia, and blah, 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 and so on. So those ones should be seen as secondary outcome measures. And like I said, you don't use your secondary outcome measure to calculate your primary, to calculate your sample size. Otherwise, your study will be not powered enough to determine the primary outcome measure. So you can see now from this example I have given that the focus of your study should be on the primary outcome measure. You have secondary outcome measures that you are still looking at, and those secondary outcome measures must also be addressed. Now, we don't usually go to calculate different sample size for secondary outcome measure. Once you get that of the primary outcome measure accurately, it's usually okay. And that is why when you finish, you notice that your study may not be powered enough to answer some of the secondary outcome measures. Like in this study, if you want, some women are receiving misoprostol, some are receiving, what do you call it? Oxytocin. And you are looking at the APGAR score or the birth weight or the complications, maternal complications like fever, shivering, and the rest of them in those women. Now, if you look at these as secondary outcome measures, you would notice that by the time you finish your study, that the incidence of people who are having shivering or having fever may be very small. That when you begin to do analysis, they may be so small, the cells may be just 2, 3, 4. You can now see that this study may not be powered for the secondary outcome measure, but it's still allowed because it's already powered for your primary outcome measure. So what I'm saying here is that always avoid using your secondary outcome measure to calculate your sample size. Now, let me address the next question here. Now, the candidate also, the same candidate asked, What is a crossover study? Now, remember I told you the types of RC, common types of RCT. You have the parallel design, you have the superiority, then you have the non-inferiority design. Now, the parallel means that you have 2 or 3 different groups, and each group is receiving one intervention, which is what is commonly done. But you have the crossover design. You could design it in such a way that at a point in time, people who receive this may cross over to receive the other intervention. And you don't see whether it will be better, the effect will be better in the people who have crossover. For instance, assuming you are using misoprostol for induction of labor, and you're also using oxytocin for induction of labor, you may design such RCT to be a crossover RCT, meaning that if you use oxytocin for a particular period of time as dissolved as defined by your study, and you notice that after a particular point in time, a fixed point, a target point, and it has not worked, you have not been able to induce labor in this woman, then you can cross over from oxytocin to misoprostol. And if you use misoprostol for a particular number of hours or doses, you can cross over to oxytocin. You are now talking about a crossover design as against a parallel design. A parallel design means that each group will receive only one intervention till the end. You set to a target point that if it gets to a successful point and this labor and this woman is not induced or has not gone into active phase of labor, that it is failed induction, and as such that you are going to terminate the process. That is for parallel design. But a better design will be a crossover design. So there are some studies that we also have crossover design, in which it may start initially as parallel, but there may be crossover, as the case may be. So these are the things that you must define clearly in your study. But you should note that not all studies should have crossover, should be crossover design. And you should also know that a better designed, designed as parallel. So none is should be considered to be better than the other. It all depends on what you are studying. Can we get today's or yesterday's recording? We send the recordings to you through the moderator and the chairman. Kindly drop your question. Okay, I'm not sure there's any other question here. Okay, I can't see.
There's another question, Prof.
I can't find any other question.
Throw more light on intention to treat in randomized controlled trial. That's from Kefas Waziri.
Okay, I didn't even see that. Now, like I said initially, when you are doing your analysis, you state clearly whether you're going to do intention to treat and whether you're going to do a protocol. Now, for the intention to treat, if you have randomized women, if following your sample size calculation, you are getting your N to be 50, and you have 2 groups. And when you finish, maybe after your inclusion, exclusion, and you have 50 women on one arm and 50 on the other arm, or 45 here and 40 the other arm, these people have been assigned to different groups. And so what it means is that if along the line, some don't complete the study, but they have already been randomized and they have started the study, you are going to put them in the analysis. For instance, if you start a study on oral misoprostol and oxytocin, and you're able to get a primary outcome data, but along the line of getting the secondary outcome measure, either that the patient, the participant decided to withdraw from the study, or the participant couldn't be reached any longer, or that something happened and you couldn't collect the data for that particular person. Your intention was to analyze all the participants in that arm. And so once the data you get, the denominator will still remain the same. So the numerator is what may change, but the denominator remains that 50 that you have assigned to the patient. So it's different because that is your intention. You intended to treat all the people in each arm. That is intention to treat. And that is usually the most preferred method of analysis for RCTs. Then you can also have a protocol where if along the line, some people, you couldn't get data from them, assuming you have, you started with 50 and you were able to get data on 50 persons, but along the line for some outcome measures, you got data in 40 persons and only 5 maybe had the rigor as a side effect. Then you are going to say maybe, if you now say 5/30, since your denominator is now 30, you are doing per protocol instead of intention to treat. But if you are doing intention to treat, your denominator remains the number of people committed to that group. And that is what is usually obtainable in the normal circumstance. So the intention to treat mimics what is obtainable in the general population. But sometimes you can also use per protocol. But for RCT, it's always advised to use intention to treat analysis. So it's something you can also check up and read them more so that you understand better. The moderator, I'm not sure, do we still have any other question here?
I don't think you have, but let's allow Professor Sunday to give his own lecture quickly before this network messes up again.
Okay.
Okay, welcome, Professor Swande.
All right.
Okay, let's get going.
Thank you very much, moderator and faculty chairman and our teachers and colleagues. I'll be talking very briefly on observational studies, cohort studies, case control studies, and cross-sectional studies. I have no conflict of interest. At the end of this session, I hope that our residents will be able to define what cohort studies, case control studies, and cross-sectional studies represent, and distinguish the differences between the 3 designs, and should be able to select the appropriate design for their proposal when they begin to write, and also avoid common postgraduate errors that occur with these studies. By way of introduction, if you look at the hierarchy of primary studies, usually we start with descriptive studies, then come to the observational studies. And above that is the experimental studies, an example of which is the randomized controlled trial that Professor Ugo very eloquently spoke on. Now, we very often see them referred to as analytical observational studies. They are considered to be analytical because they are used to study association between exposure and outcome, risk factors and disease. And they're also considered observational because the researcher does not intervene in any shape or form. So there are basically 3 types: the cohort studies, case control studies, and the cross-sectional studies. For practical purposes in both colleges, West African College of Surgeons and Dear National College, majority of these proposals we see for the fellowship or Part 2 exam, this is where they border around. So it's important that all residents have a very firm grasp of this. We'll start quickly with the cohort studies. By definition, the cohort study begins with the exposure. Participants are recruited into cohort studies based on exposure. And that exposure could be risk factor to a disease and so on. Now, having recruited the participants are now followed over a period of time to see if that disease will manifest. And that disease or outcome is now measured subsequently. So the key question under cohort studies is, does exposure lead to disease? Does exposure lead to disease? The structure of cohort study is very simple. First, you identify, and by the way, cohorts refer to a group of participants with similar characteristics. And where they differ is the primary factor you want to study. So you group them into 2. One group is exposed to a particular risk factor or condition that could lead to a disease or condition. The other group is unexposed. You ensure ab initio from the beginning that at baseline, the participants both in the exposed and unexposed group are free from the disease condition or the outcome you are hoping to look out for. And you now follow these two groups over time and see those in either group that will develop that condition or disease. And when that happens, you compare the incidence of the disease that developed in the exposed group and versus that occurred in the unexposed group. It stands to reason that if at the end you have more of the disease occurring in the exposed group, you cannot begin to talk of that exposure being causative to that outcome or disease. And similarly, if you have the condition occurring more in the unexposed group, or let's leave it at that. So the important aspect is that we follow the participants longitudinally. And so we are able to measure the incidence for the exposed group, the incidence for the unexposed group. And it's important we take note of this. This is where sometimes candidates make errors. So the incidence rate is the measure of analysis used for cohort study. Now let's look at an example of a cohort study. In this example, the researcher was looking at the effect of booking status on increase in maternal mortality. So the exposed group were those that were unbooked. They didn't book those pregnancies, whereas the unexposed group were those that booked for the pregnancy. And the outcome measure that we're looking for was maternal mortality. The measure used in analyzing here for cohort studies is what they call the relative risk. Simply put, is the incidence of the disease or condition in the exposed divided by the incidence of the condition in the unexposed group, having followed both groups longitudinally. When that ratio or relative risk is 1, it means that that exposure or risk factor does not in any way affect the outcome of the condition in question. However, if the relative risk is greater than 1, implying that the incidence in the exposed group was higher than the incidence in the unexposed group, it means that exposure somehow contributes to the causation of that disease condition. Again, if the incidence of the unexposed is higher than that of the exposed, it simply infers that that exposure actually confers some protection. It's protective somehow to that condition coming up. So for cohort studies, the measure we use is the relative risk. This is to be stressed. Now, what are the pros and cons of cohort studies? The very first advantage is the fact that we can measure incidence between the exposed group and the unexposed group. Again, it has the advantage of having a clear temporal relationship, because from the beginning you picked the exposed, you recruited based on exposure to a risk factor, those that were exposed to it, those that were not exposed, and you followed both groups longitudinally over time and watch in which group or to what extent in each group the condition manifested. So you can beat your chest and say, yes, this exposure can actually predispose or cause this disease. Again, you can use cohort studies for multiple outcomes. For instance, in the study to look at, there's a study of exposure being tobacco, and you want to look at the outcomes. You can study multiple outcomes like cancer of the lungs. You could study cardiovascular disorders. You could also study at the same time cerebrovascular accident using a cohort study with just one exposure. When we get to the case control study, you see that that's not particularly very feasible. It has very obvious limitations. The first one is that it's expensive, considering that you have to recruit patients and study over time. In some of these conditions, depending on what you are studying, you have to follow up over very long periods of time. For instance, if you are studying the effect of positive human papillomavirus typing and cancer of the cervix, that may take you 10, 20 years, as opposed to if you are studying something about labor, which is an event that occurs in a few hours, you could. So it depends on the life, natural history of the condition you are studying. But generally, you have to follow, so it's expensive. It's also time-consuming, and there's that risk of loss to follow-up. If you remember, when we get to the methodology of proposals, we are all, it is because of that possibility of attrition, losing some of those patients because of that longitudinal follow-up, that we have, you give a 10%, cap to your sample in case you lose people to follow up. That will take us to the case control study. By definition, the case control study begins with the outcome or the disease condition. So clients or respondents are recruited into the studies based on they having a particular outcome or disease. You now work backwards, retrospectively. That's why they are also called sometimes retrospective studies, backwards to try to assess the effect of certain exposure to that outcome. So more or less is the reverse. It's the opposite of, more or less, loosely put, of what you do in the cohort study. The key question here is what exposure actually caused this disease? Now, the structure of case control study is again straightforward. First, you identify cases and controls. The cases are individuals with the disease condition or the condition outcome we are talking about. Maybe diabetes in pregnancy, cervical cancer, name it. What depends on what you are studying. And the controls are suitably matched individuals who do not have that disease condition. So you have cases that have the disease condition already established with them, diagnosed, okay, and the controls that do not have that disease condition. You now look back into their past and try to investigate if certain exposure, particularly well-defined exposures, what role or how prominent were they in the cases, how prominent were they in the controls, and you compare the frequency of these exposures. If the exposure, for instance, is more with the cases, that may explain to you why they have that disease. And if they were lower, of course, in the controls, it may strongly suggest that that exposure contributed somewhat to the development of that condition or outcome. Now, let's look at an example of a classical case control study. If we were to study the risk factors of cervical cancer in a certain hospital in Nigeria, then the cases will be women with established, histologically confirmed cervical cancer. The controls will be women without cervical cancer, and the exposure in this particular study that they try to look at that may explain why some had the outcome and others did not. Here we use early sexual debut, for instance, and positive human papilloma virus typing. The measure of analysis used in the case control study is the odds ratio. That's the odds of the exposure causing the outcome in the cases and the versus the odds of the exposure causing the outcome in the controls. So whereas we use relative risk for cohort studies, the measure here is odds ratio. Very often we see candidates swapping and misapplying this. Now, what are the advantages of case control studies? The case control studies are ideal for very rare diseases. For instance, you want to work, let's say in gynae, you want to look at the prevalence of, say, fallopian tube cancers. They are pretty rare. They are pretty rare. So if you want to do a longitudinal study, it will take you 20, 30 years or more to even get just a few. But you could go back to your archives, look at your data, pick maybe 1, 2, 3, 4, 5 cases you've had in the past 10, 20, 30 years. And now with that limited sample, look at the risk factors or outcomes that they had that predisposed them to that. So that's one very, very prime advantage they have. Again, they are faster and cheaper to conduct compared to the cohort studies. And like I mentioned, you could achieve that with a small sample size. The limitations, of course, are obvious recall bias when you have to go retrospectively to get information or interview the client or search through their records. You may also have difficulties. Selection bias is there. And again, unlike in the cohort studies, you cannot measure incidence. That will take us to the third design, which is the cross-sectional study design. Unlike the other two, the cohort studies recruits patients or clients, or rather, based on exposure, whereas the case control recruits based on outcome. In the cross-sectional study, you take both at the same time from the onset. Exposure and outcome are assessed at one point, and there's no follow-up period. You don't follow up forward nor backwards. The key question here is, what is the association between the exposure and the outcome? And many of our candidates, pre-part 2 candidates, usually pick studies that fall into this category. The structure is pretty straightforward. You identify cases and controls. You assert, and when you've done that, you could try to ascertain the relationship between the exposure and the outcome by comparing the frequencies of both exposure and outcome. The principal factor here being that you take all your variables, both the outcome variable, that's your dependent variable, and the independent variable at the same sitting, and you don't follow up these respondents. Now, let's look at a typical example of a cross-sectional study, a study that wants to look at the risk factors for cervical epithelial neoplasia. It may be a setting in Nigeria. The cases will be women with CIN established, whereas the controls will be women without CIN. And the exposure, again, you may wish to use the same early sexual debut and human papilloma virus infection, and the outcome will be CIN. So when you get the two groups, you identify those that are cases, identify those that are controls, and do not have that particular exposure you are looking at, in this case, early sexual debut and human papilloma virus. And you will now try to compare the two. Which one has more of this? Again, you are not following. The measure of analysis here is the odds ratio. It measures the prevalence, just like the case control study. Now, what are the advantages of cross-sectional studies? First, they are very fast compared to the other methods to conduct. They are cheaper. They are indeed the best way to determine prevalence. And prevalence, by the way, talks about the volume, the number of people with a particular condition in a defined population at a point, say today, 21st December 2025, as opposed to incidence, which the cohort study uses, which follows the number of new cases or new cases of a condition or disease that develop within a stated period, say January to December 2024. So it's good we have a clear understanding of that. And the limitations of the cross-sectional studies, the first is the very fact that it's difficult to differentiate between cause and effect, because you took the exposure and the outcome at the same time. You took the risk factor and the disease condition in the same patient at the same time. So you cannot clearly say with certainty that it's that risk factor that led to that disease. Or indeed, is that just is it an effect or even that disease? You cannot say, because you didn't do a longitudinal follow-up. That's a major limitation with cross-sectional studies. So for this reason, most people will use them as an initial means to establish a relationship of association between an exposure and an outcome before they will now subject the study to a higher level, such like cohort studies or maybe even experimental studies. Again, it cannot efficiently study rare conditions for the obvious fact that you are just taking your variables at one point. So of the three, this is the one that cannot at all even be used for rare conditions. Again, incidence is not measured here. A quick table to contrast cohort studies, case control studies, and cross-sectional studies. Let's look at a feature like what you start with. For cohort studies, you recruit clients based on exposure. So you get a risk factor, and on that basis, you get your cases, your controls, and follow. For case controls, you recruit them based on them having that established disease condition. Then you look backwards to try to find certain exposures that could have explained that. For cross-sectional studies, you take both exposure and outcome at one point. In terms of direction, for cohort studies, you follow longitudinally moving forward, whereas for case control studies, you move backwards. You get the disease that is established and try to move backwards retrospectively to find out certain exposure that may explain that. For cross-sectional studies, it's just a point study, so you don't go forward, you don't go backward. The measure of analysis in cohort study is the incidence, so you could do the relative risk. And for the case control and cross-sectional studies, you use prevalence, so you do the odds ratio. Again, the odds ratio is usually very close, by the way, to the relative risk, even though there are different tools. For rare diseases, again, the cohort study is poor. It's a poor option to choose. The case control will be ideal for the fact that you could look back very quickly, pick a few cases of the rare condition you have, and then dig into their history to associate exposure with the condition. The cross-sectional study is even a poorer design to attempt to use for rare disease conditions. So when you are making your decision, you have to make the right decision. If it's a rare disease you want to look at, the case control may be the ideal. If it's a common exposure, the cohort study. If you have limited time and funding, the case control will come in very handy. And for prospective, if you have prospective data available, you could use the cohort study. I also forgot to mention that the cohort studies are of two varieties. I was tempted not to mention this, but I should mention. You have the prospective cohort and the retrospective cohort. If you are lucky to have a situation where you have retrospective data that is very intact, very well meticulously kept, you could still apply the cohort study that I had earlier mentioned, that you follow patients forward longitudinally. And what do? You go back to the data. Remember, in cohort studies, you start by first isolating the exposure. So based on the data, you isolate or recruit your participant based on a particular exposure or risk factor of your choice. Then you now follow their data and see in both groups what the quantum of participants that developed that condition eventually. So there is an entity called retrospective cohort. But the classical teaching about cohort study is the forward or longitudinal follow-up. What are the common examination pitfalls we see? Very often you see a client, for instance, will do a classical cohort study, but he will name it cross-sectional study. And I give an example. I saw a work in which the candidate tried to look at the effect of serum progesterone levels at day 14, and the outcome measures were the implantation rate, the pregnancy rate. So he had a cutoff about 3 thresholds of the levels of serum progesterone, and he wanted to see the categorized patient into those 3 and follow them. And in each of those 3, he tried to look at the implantation rate as well as the pregnancy rate. I think at the 14, week 4 weeks and 6 weeks. But he called that cross-sectional. That cannot be a cross-sectional study because you are taking your measurement, your variables in that client over a long period of time. At 14 days, you took the serum progesterone levels. At 4 weeks from that, you looked at implantation rate. 6 weeks from that, you looked at pregnancy rate using transvaginal scan. So that cannot be a cross-sectional study because it's not a snapshot. You did not take all those measurements at the same point. It was over a long period. There's that mistake to consider cross-sectional studies with the classical study of tobacco and lung cancer, which takes years. It depends on the natural history of what you are studying. Some cohort studies can last for a few hours, depending on the natural history of what you are studying. Now, again, correct measures of association are very frequently used. You see someone doing a case control study and he's talking of relative risk. The relative risk is calculated using incidence. That is the number of new cases that develop within a stated period. So, since you did not follow the patient longitudinally, you cannot be talking of relative risk in case control studies or in cross-sectional studies. Again, sometimes they choose their controls very poorly and have problems. Again, when you are doing observational studies, you must define the exposure and the outcome very precisely so that what falls within that definition is taken to be it, and what does not fall within that is excluded. Another major exam pitfall we notice, like Prof. Sugu mentioned earlier, in randomized controlled trials, he was stressing the issue of consult flowchart. For observational studies, you use what they call the stroke guidelines in reporting. That strengthening the reporting of observational studies in epidemiology. If you don't use it, you also lose marks and challenges come up. So, finally, what are the take-home messages? The overall is the fact that the correct study design is the backbone of a successful proposal. But specifically for cohort studies, they look forward in time by following up each subject. Subjects are selected before the outcome of interest is observed. They establish a sequence of events. Numerous outcomes can be studied, and they are the best way to establish incidence of a disease. They are a good way to determine causes of diseases. The principal summary statistic of cohort study is the relative risk ratio, which uses the incidence rate. If you are doing a prospective cohort, they are expensive and often take a long time for sufficient outcome events to occur to produce meaningful results. So if you are choosing your topic, it will be foolhardy, for instance, to go and look at the effect of, say, human papilloma virus DNA typing positivity and outcome of cervical cancer. Because you need 10, 20 years, and before you do that, it obviously doesn't sum up. So you need to be careful when you are choosing. For the take-home message for case control studies, that they look back at what has happened to each subject. Subjects are selected specifically on the basis of the outcome of interest. They are cheap and efficient. They produce the odds ratio that approximates to the relative risk for each variable studied. They are prone to sampling bias and retrospective analysis bias, and only one outcome can be studied at a time. And that is because you first recruit your clients or respondent based on the outcome of disease condition. So you are only going to be able to analyze based on that condition you are choosing ab initio. And finally, for cross-sectional studies, they look at each subject at one point in time only. Exposure and outcome are taken at the same time. It's relatively less expensive. The best way to determine prevalence is quick. And the principal summary statistic of the cross-sectional study is the odds ratio. Unfortunately, it has a weaker evidence of causality than cohort studies. And they are inefficient when used to study very rare conditions. Thank you very much, moderator.
Wow. Professor Swende, thank you very, very much. Please, can we also give him the E round of applause, please? Let it keep coming. Okay, Professor Adeshino, I don't know whether you're with us. If we can just tidy up, please. Professor Adeshino. Prof. Adeshino. Okay.
I don't think she can join. I think she's been trying to. Let's just take the
Yes.
questions for this second presenter and round up.
All
We'll send the
right.
slides on the platform then.
Okay. So, Professor Swende, please, let's go to your questions.
Okay.
I think somebody says, thank you very much. Please, what are the differences between the retrospective cohort study and the case control study. Also, kindly shed more light on the classification of cohort study.
Okay, thank you. This was the reason why I was tempted not to mention the retrospective cohort, because people like to hear things that sound very rather strange. So, like I mentioned, for case control studies, you recruit patients. The focus from the start is the disease condition or the outcome. So in case control, you recruit people into your study based on they having a particular outcome or disease. Okay, that's the basis. As opposed to a cohort study where you recruit them based on exposure. And having recruited based on exposure, you now follow them longitudinally over a period of time, depending on the natural history of that condition, so that you can see the participants that will develop the condition in both arms, and you can now compare. That is for cohorts, straightforward prospective cohorts. Now, for the variant of retrospective cohort, which you are asking me to differentiate from case control, you still do the same thing you do in a cohort, a prospective cohort, in that you recruit your clients based on exposure, not they having the disease. So you still recruit them based on exposure, but you are privileged to have the data available. So you go back to the data of the people you want to recruit from the beginning. Look at those exposures. If you are lucky it was documented, you will now recruit them into two groups, one with the exposure and the other without the exposure. Okay, you will now follow their records. Okay, or they will, let's say you did, when you check their records to 2010 for a particular condition, you saw the exposure categorized into the exposed and non-exposed. You now follow their records from 2010 until, say, 2015, and try to document or see the numbers that developed the disease in those that were exposed and those that were not exposed. And you can now calculate the incidence and still get the similar result like the prospective cohort. This is to be differentiated from a case control study where you recruit your participants based on they having the outcome or disease condition. For example, establish cancer of the cervix, if that's what you want to look at. Then you now move backward retrospectively to try to see in between your cases and controls who had more of the exposure or risk factor you are studying. So they're actually different. That's why for me, I prefer people getting it the way I presented first. And as you get your orientation, you can now easily identify what the retrospective cohort is. But by and large, that is it. Someone was also asking about classification of cohorts. So I guess what I've done now has explained that. You could have the prototype, the traditional teaching is the prospective cohort that I elaborated more on. And the other variant is the retrospective cohort. Thank you, moderator.
Thank you very much. I think there are other questions too, but they seem to be referring to the first presenter, Professor Ugu. This one
Yes, he can also answer it too. Doesn't matter.
This one says, a study that seeks to understand the association between ultrasound-derived estimated fetal weight and perineal tear in nulliparous women in a teaching hospital. Is it a prospective cohort study? Okay, I think this is for Professor Swende. And will Cochrane's formula be used to calculate the sample size? Thank you, sir.
Well, you may not from the title alone know the design used, especially when the title is not worded using the PICO acronym, you know. So it depends. From the way you framed it, this could even be a retrospective study, it could be a descriptive study, it could be cohort, depending on how you plan your design. So it's sometimes not just from design, except the author or the candidate uses, like I said, the PICO to get a very well-framed title, so that from the title you can know whether it's a cohort study, it's a randomized control study. But from what you have said, several other designs can maybe applied. For instance, you are talking of using ultrasound determined. Well, I didn't get that. Moderator, you said
ultrasound derived estimated fetal weight and perineal tear.
Good. So in this one, for instance, the outcome measure the outcome measure or disease condition of perineal tear, the exposure will be what? Estimated fetal weight. So you may have a cutoff. Maybe you say 4 kilograms and above and less than 4. So you can now follow, if you follow them longitudinally, okay, that can be a perfect cohort study.
Okay, yes.
Okay. You may also wish to take it to a randomized control trial. No, let me not go there. That may not be perfect because you are not directly intervening. Then again, you can still apply the case control study in the example you are giving. If you can pick women who had perineal tear after they delivered, so you are recruiting them based on having the disease condition, the perineal tear. You now look into their records or interview them and try to find out what were your birth weights for that particular pregnancy. You see that I'm going backwards. So I could still apply a retrospective case control study for that too. So it depends really on what the researcher wants to do. But remember, the validity and the level of evidence for a cohort study is higher, and it links causation better and at a higher level than your case control study. So if you were to apply both, you would rather favor using the one that carries higher evidence so that whatever you get, people will take it more serious.
Okay, will Cochrane's formula be used to calculate the sample size?
I think Ugo was the one talking of Cochrane's formula for randomized control trials, if I'm not mistaken. Yeah.
But then we talk about Cochrane.
Okay, yeah, Prof, you are here.
Don't understand what he's talking about Cochrane formula. Is that not that cross-sectional formula that he's talking about?
Okay,
you won't use the Cochrane formula for that kind of study design, which, as Professor Swende said, is the objective of the study. You have not told us. If you tell us your primary objective, we then know the better sample size, the better formula to use, and the better design to call it. So you can't just from the title, especially when the title is not clear, and you start asking for the study design and start asking. You are the one doing the study, you know exactly what you want to achieve. You tell us your primary outcome measure, we'll be able to know what the design should be and the appropriate sample size calculation to use. The Cochrane formula should be limited majorly to cross-sectional study, especially prevalence studies. So once you have a case control study, you have a cohort study, you should be talking about difference in mean, difference in proportion, because you're not talking about the hypothesis-driven research. You don't use a Cochrane formula and be talking about and be doing a hypothesis-driven research. So the Cochrane formula should be used as a limited use, except when you are doing cross-sectional prevalence or descriptive studies.
Okay, thank you very much.
Otherwise,
Professor.
most times, okay.
Okay, sorry, I thought you had finished. I'm sorry.
No, I'm done. I'm just trying to tell candidates. Candidates often limit their sample size calculation using the Cochrane formula, which even though applicable in some cases, but you notice that most times the Cochrane formula they use is usually not applicable for hypothesis-driven research, which is expected at postgraduate level. So I do not think that the Cochrane formula should be appropriate for this design in the interim. Though, as Professor Sweden said, we don't have details to begin to say what the study design should be and what the appropriate sample size formula to use should be until we get more details. Thank you.
Thank you very much. Now, another question says, please, sir, in a case where there is a disease condition like hypertension, and you want to compare the efficacies of two antihypertensive drugs. Can this be done as a cohort study?
Okay, thank you for that question. The emphatic answer will be no, because in observational studies generally, the researcher does not intervene. So this one now goes up to experimental level studies, designs, where you start introducing two different medications to study. You've already intervened. You are no longer observing. You are actively intervening. And that is the reason for which the experimental studies came up. Because in the observational studies, you don't change anything. Okay? So you may look at a certain condition, what do you call it? Exposure that can cause an outcome. But in between that exposure and outcome, there are several other conditions called confounders that can affect both the exposure and the outcome, and therefore contribute also to the outcome. Cohort studies attempt to control for this, but it's difficult. They attempt to control by using inclusion and exclusion criteria, where you can already work out possible factors that can affect it. And they can also use statistical tools at the end to try to do regression and all of that to see if they can counter for that. But it's for this very reason, that will now move those up to experimental studies. So for this particular example you gave, you are already intervening. You are giving two medications to two different groups that can no longer be observational. You are not just sitting, sit, don't look. You are actively intervening. So that's not an observational study. Thank you.
Okay, thank you. I think I just found one on unanswered question. And I think it's for Professor Ugu. Is it advisable to use power of 95% to calculate sample size?
Okay, thank you, the moderator. I think I've answered that and posted there. I don't know why candidates will be looking at 95 when he has not even used 8. What is mostly recommended and acceptable is 80. If you use 80% power, it should be able to give you a sample size that is appropriate, and that should be powered enough to determine your outcome measures of interest. At most 90. For you to go to 95%, that's being ambitious. It's always good to limit it to 80. Generally, it's 80% power that is used, and sometimes 90. But to use 95% power, yes, we can use 95% power. But what is most commonly used is 80%, and sometimes 90%. But 95 is rare and not commonly advised to use 95% power. Yeah. Except
Okay,
if you are
thank
doing,
you very much. I don't know if there are any other questions from the participants. So if there is none, I want to say a big thank you on behalf of all of us to Professors Ugu, Adeshino, and Swende. They have really exposed how we should write our proposals for randomized control trials, cohort studies, case control, and then qualitative and mixed methods of research. And so I want to once more give them a resounding round of applause. Thank you very much for your time. And may I call upon the secretary to please speak to us, give us a vote of thanks, please. My secretary, sir.
Good evening. Sorry, the secretary is in transit.
Oh, okay. So my chairman.
So So good evening, senior colleagues and colleagues. Let me, on behalf of the faculty, thank everybody. Thank all our teachers. We thank the presenters today, Professors Ugu, Swende, and Adeshino. And apologies for Professor Adeshino's fluctuating network. but the slides will be sent. Let me also thank Madam Moderator, our new CMD. We're very proud of you. Thank you very much. And let me thank the residents too. This program, this series of webinars have been designed for primarily the residents so that you can have a clearer view of how you need to approach the proposal writing for the Faculty of Engineering National Postgraduate College. And I think it may also help you with the West African College, our sister college. It's a combined seminar for both residents and trainers. We have a few more seminar webinars to go, so please stay tuned. You'll be getting the flyers from the secretary very soon. This is just to ensure that we are all on the same page. So let me thank everybody and wish you all a wonderful week and a Merry Christmas and a wonderful New Year. Thank you very much and God bless.
And God bless you too, my chairman. God bless all of us. Happy Christmas. Merry Christmas.
Bye.
Good night.
Moderator and CMD. Bye-bye.
All right. Thank you very much.